Hi, folks. Thanks for joining me for the third portion of this series about two primary disorders of hypersomnolence on Hope in the Pipeline. Today, we're going to pick back up on our discussion by focusing first on medication treatment of narcolepsy. Then we'll move on to the differences between narcolepsy and idiopathic hypersomnia. And finally, I will touch on some of the exciting research going on at Preferred Research Partners with these two disorders. Medication commonly used in the past for treatment of narcolepsy includes the category of stimulants, and this category includes medicines such as Ritalin, Concerta, or generic methylphenidate, or Adderall, Digoxin, or generic amphetamines. And these medications are effective in helping someone with narcolepsy maintain alertness, but they tend to wear off quickly. They may cause side effects such as weight loss, nervousness, mood changes, a fast heartbeat, and unfortunately, tolerance to their beneficial effect tends to develop quickly. These medications also have a fairly high abuse potential. There was another medication called Cylert that I used around 1995 or so that was helpful with excessive daytime sleepiness in some patients that were unresponsive to methylphenidate or amphetamine. But unfortunately, it got linked to the potential for liver injury and taken off the market. Other medications that help our brain to maintain wakefulness include modafinil or Provigil, or the slightly longer-acting armodafinil or Nuvigil. These two medications aren't habit-forming like the older stimulants, and they don't have as much impact on mood or blood pressure or heart rate, and their side effects are not as common, but still can include headache, nausea, or anxiety. Years ago, I helped test these medications during their developmental clinical trials for the treatment of excessive daytime sleepiness in narcolepsy and for excessive daytime sleepiness from sleep apnea. Unfortunately, none of the above medications that I've mentioned is fully effective throughout the entire day for treatment of the excessive daytime sleepiness in all patients with narcolepsy. In fact, in some patients, they have very limited impact, and some patients can't tolerate their side effects. So as a result, newer medications have been developed. Solriamfetol, or Sunosi, and Pitosalant, or Wakix, are two newer stimulants used for narcolepsy, and they tend to last a bit longer, again have fewer or milder side effects, or work more fully to help maintain alertness than previous medications. At Preferred Research Partners, we have helped test the effectiveness of Sunosi, a dopamine-enhancing agent, in treating excessive daytime sleepiness in narcolepsy, sleep apnea, and for shift work over the past few years. Older medications, used specifically for the treatment of cataplexy, include what are called tricyclic antidepressants. And these older antidepressants, for example, protriptyline and clomipramine, can help reduce cataplexy. But they can cause side effects such as dry mouth and lightheadedness and blurred vision and constipation and changes in the heart rhythm, and even worse in this disorder, they can cause drowsiness. Starting around 1988, the SSRI antidepressants, such as Prozac and Zoloft, and the SNRI antidepressants, such as Cymbalta and Effexor, were developed. These antidepressants featured fewer side effects and more safety than previous antidepressants that were used for cataplexy treatment, and so they began to be used off-label for the treatment of cataplexy. All of these antidepressants work by suppressing, but not eliminating, REM or dream sleep, and they can help not only with the cataplexy, but with sleep paralysis too. However, these antidepressants are usually only partially effective and have unique side effects of their own, such as GI disturbance, insomnia, agitation, weight gain, and sexual dysfunction. And so, the search for better medication continues. Better in terms of effectiveness, duration, fewer side effects, and how about developing something that can treat both the excessive daytime sleepiness and the cataplexy? Fortunately, in 2002, a medication called Xyrem, or sodium oxybate, was developed by Jazz Pharmaceuticals. This medication was unique in being a liquid that needed to be taken 2 or 3 times a night. Yet the positive effect of this medication in reducing arousals from sleep, improving sleep depth, and in treating excessive daytime sleepiness in narcolepsy was quite astounding. Subsequently, Xyrem has been demonstrated to also be effective for reducing cataplexy, and was approved by the FDA for this additional purpose around 2018. Since then, multiple forms of sodium oxybate have been developed to help the medication last longer and to be less salty. These new options include Limriz, which can be taken once a night, and Xywav, which is a lower salt load option. Another medication called Pitosalant or Wakix was approved in 2019 and is a unique medication impacting the histamine receptors in our central nervous system, which some subtypes of patients with narcolepsy may respond well to for treatment of their excessive daytime sleepiness and their cataplexy. Now I'm going to change directions again and talk about another sleep disorder called idiopathic hypersomnia, which I might refer to as IH during this discussion. Idiopathic hypersomnia, or IH, is a neurological disorder which is characterized primarily by excessive total sleep time, and despite the excessive total sleep time, by bouts of overwhelming excessive daytime sleepiness. The term idiopathic means its cause is currently unknown. This disorder was first recognized as a condition in 1976. Typically, the symptoms of idiopathic hypersomnia begin in adolescence or young adulthood, although they can begin at a later age. After onset, the hypersomnia or excessive daytime sleepiness often worsens over several years and appears to be a lifelong condition. Spontaneous remission is seen, though, in roughly 12% of patients. Unlike narcolepsy with cataplexy, which has a known cause, the cause of idiopathic hypersomnia remains a mystery. It could be caused by the destruction of noradrenergic neurons in the brain or by some other malfunction of the norepinephrine system. It could also be related to low histamine levels in our cerebrospinal fluid. Idiopathic hypersomnia affects 2 females for every 1 male, and cases within families are frequent, with 25 to 66%, depending on the study, having another affected family member, but without any clear mode of inheritance. Idiopathic hypersomnia is considered a rare disease, believed to be 10 times less frequent than narcolepsy, affecting only about 1 in 25 to 100,000 people. Just like narcolepsy, there are 2 subtypes of idiopathic hypersomnia, with and without long total sleep time. Like narcolepsy, idiopathic hypersomnia typically starts in early adulthood, and most patients diagnosed with idiopathic hypersomnia will unfortunately have had the disorder for many years prior to their formal correct diagnosis. It is also important to note that compared to narcolepsy, which is strongly associated with the HLA-DQB1-0602 gene, genetic testing is currently of no help in the positive diagnosis of idiopathic hypersomnia. So, what is the suspected cause of idiopathic hypersomnia? We are not sure, but recently some people were found to have an abnormal hypersensitivity to GABA, that is gamma-aminobutyric acid, the same chemical that is affected by the medication Valium, and which is the major brain chemical responsible for sedation. There was a small protein found in the cerebrospinal fluid of affected patients, which is currently referred to as a somnogen, because it has been shown to cause hyperreactivity of the GABA-A receptors in our brain, which then leads to excessive daytime sleepiness. In essence, the theory is like these patients' brains are chronically sedated with Valium, even though they do not take these medications. Again, similar to narcolepsy, the main symptom of IH includes excessive daytime sleepiness. But in addition, about 45% of people with IH will also have severe sleep inertia, which is a prolonged difficulty waking up from sleep with repeated brief returns to sleep combined with irritability and severe brain fog. People with idiopathic hypersomnia also have very long periods of unrestorative sleep, including naps from which they awaken largely unrefreshed, despite when we look at their brainwaves, the quality of sleep being very good. It is very difficult for patients with IH to wake up to an alarm clock, and most end up using multiple different overlapping methods to help themselves wake up. The excessive daytime sleepiness in idiopathic hypersomnia is different from the excessive daytime sleepiness in narcolepsy, in that it is often combined with the general lack of energy during the day after apparent, adequate, or even prolonged nighttime sleep lasting 9 to 14 hours. The person with IH does not really ever wake up refreshed, whereas patients with narcolepsy can and do wake up refreshed, although it doesn't last as long in terms of helping them maintain alertness as desired. People with IH may experience inattention, slowed thought processes, and comprehension abnormalities, which in turn can negatively affect perception, memory, learning, executive functions, language, voluntary motor control, and mental processing speed. Some affected individuals can complain of forgetfulness, confusion, or inability to think clearly, all due to the inability of the brain to reach full alertness and to stay there. Some people with idiopathic hypersomnia have what's called autonomic dysfunction, and so they experience increased frequencies of palpitations in the heart, digestive problems, or difficulty with body temperature regulation. Anxiety and depression are often noted in patients with IH, but we are unsure if this is part of the disorder itself or a response to the chronic difficult illness. Anxiety and depression are often noted in patients with IH, but we are unsure if this is part of the disorder itself or a response to having a chronic difficult illness. Cold hands and feet are more common in people with IH than in the unaffected population. Other autonomic dysfunction systems include fainting from low blood pressure, dizziness upon arising, headaches, food cravings, and impotence. All are more commonly present in patients with idiopathic hypersomnia. Now, idiopathic hypersomnia is diagnosed much in the same way as narcolepsy, starting with a very careful lifelong clinical history and keeping a sleep diary. About 30% of patients with idiopathic hypersomnia can identify a positive family history for the disorder. Use of actigraphy, a nighttime sleep study, and traditionally a daytime MSLT are also standard tools for diagnosis. The onset of idiopathic hypersomnia is usually around age 16 and a half to age 21. Now, unlike the link between narcolepsy and autoimmune dysfunction, with idiopathic hypersomnia, there is no known triggering agent. At this point in time, genetic testing, as I said before, is of no help in confirming idiopathic hypersomnia. The multiple sleep latency test in IH, those results are generally not going to show sleep onset rapid eye movement episodes. And the sleep quality, continuity, and duration during the nighttime study are going to be much better and longer than in someone with narcolepsy. There is also likely to be significant prolonged grogginess and inertia present on waking. Interestingly, some of the latest research studies have questioned the usefulness of a standard MSLT test in diagnosing IH. Several groups of researchers have found a normal multiple sleep latency test result to be present in IH patients, and so instead have suggested using a 24-hour continuous sleep study. Now, let's move on to talking about treatment for idiopathic hypersomnia. As of August of 2021, the FDA approved the first medication for treatment of idiopathic hypersomnia called Xywav. There are a variety of other medications used off-label for IH treatment, basically the same ones mentioned in previous episodes when I spoke about narcolepsy treatment options. And these include amphetamines, methylphenidate, Provigil, Nuvigil, Wakix, Sunosi, etc. There is no need for any cataplexy treatment in people with IH. Research is ongoing into the benefit of using a gamma-aminobutyric acid A receptor blocker. The blocker blocks hyperactive GABA receptors in order to treat idiopathic hypersomnia. These medications include clarithromycin and flumazenil. Clarithromycin is an antibiotic used for the treatment of infections, and it has been found in a couple of studies to return the function of the GABA system to normal in patients with IH. But other studies have found evidence of its effectiveness to be inadequate. And the American Academy of Sleep Medicine's 2021 clinical practice guidelines conditionally suggest the use of clarithromycin, especially for those idiopathic hypersomnia patients who don't respond to other therapies. Years ago, I attempted treatment of one of my IH patients with clarithromycin, and unfortunately, it was of no benefit. I think most likely clarithromycin is helpful in a unique subset of IH patients whom we have yet to determine how to identify ahead of time. Flumazenil, though, is quite an interesting medication to me as a treatment option for idiopathic hypersomnia. It is a GABA A receptor blocker that is approved by the FDA for use in reversing anesthesia and benzodiazepine overdose. Remember that, as I said before, in IH patients, their cerebral spinal fluid contains the unknown somnogen, the small protein I mentioned that enhances the function of GABA A receptors, making them more susceptible to the sleep-inducing effects of GABA. And research has demonstrated in a few patients so far that flumazenil given daily by sublingual, which is under the tongue lozenge, or a topical cream has been effective in terms of treating idiopathic hypersomnia. And there's also a case report from a few years back that showed improvement in IH symptoms after treatment of a patient with subcutaneous flumazenil, which is just under the skin. The patient was treated with short-term subcutaneous administration over 96 hours at 4 milligrams a day of flumazenil, followed by a slow-release long-term administration of flumazenil through an implant under the skin. Still, however, the search for better treatments for narcolepsy and idiopathic hypersomnia goes on. At Preferred Research Partners, I am pleased to announce that we are privileged to partner with Alkermes Pharmaceutical Company to help them test a new medication for treatment of not only narcolepsy types 1 and type 2, but also for idiopathic hypersomnia. This medication being tested is thought to be a strong hypocretin or orexin type 2 receptor stimulator that promotes and stabilizes wakefulness and may block cataplexy. Most importantly, I'm pleased there is also an ongoing search for prevention or cure or reversal of these two disorders, not just a search for treatment. And I think that the key to achieving these goals lies in learning how to regulate our immune system to prevent the disorders from ever developing, or to prevent their progression via early identification, or perhaps to reverse them, maybe by getting the body to start producing its own orexin again. We are currently looking for individuals ages 18 years and up who suffer from or think they might suffer from type 2 narcolepsy without cataplexy or from idiopathic hypersomnia to further test the effectiveness and safety of this new medication. These are paid clinical trials lasting 12 to 21 weeks, with the opportunity after that to be in a 2-year-long extension study with free access to the study medication during that time. We can assist with the initial diagnosis of narcolepsy or idiopathic hypersomnia in people who think they might have one of these disorders but have never been formally diagnosed at a sleep center. So if you or a loved one or a friend knows someone who has or might have narcolepsy or idiopathic hypersomnia and think that they might be interested in exploring the possibility of joining this clinical trial, please check out our website or direct them to our website at www.preferredresearchpartners.com to learn more about these studies. As always, please like, rate, and review my podcast, which helps more people to find it and to learn from the content. If you know someone who you think might benefit from viewing this podcast episode, or any of them in this series on hypersomnolence disorders, please share it with them. As always, thanks so much for listening to today's presentation and to this whole series on hypersomnolence disorders on Hope in the Pipeline. We'll see you again next time when I will start a series on gastrointestinal disorders. Until then, stay safe and stay well.